All right, hello everybody. Thank you so much for joining. Welcome to our speaker series today. Today, our discussion is going to be all about pain. We're just getting started. We're going to let people join our Zoom, so bear with us for a quick second while we let everybody get in on the Zoom webinar. Really excited for this conversation today, and a special thank you, Dr. Linda Bluestein. I'm pronouncing that correctly, right? I should have checked
Yes.
with you before. Dr.
Yep.
Linda Bluestein is joining us, and Dr. Linda Bluestein of Hypermobility MD, or Hypermobile MD.
You had it right. Hypermobility MD. Yep.
Hypermobility MD, forgive me, Hypermobility
Okay.
MD. So this is going to be a great discussion. So before we get started, I'm going to stop sharing the screen in a second, but just wanted to remind everybody that we are open for questions. Please find the Q&A box at the bottom of your screen. Type any questions in there, and we will try to get to as many questions as we can. However, we're anticipating a lot of questions, so please bear with us. If your question doesn't get answered, we're going to do our best to get through as many as we can. Secondly, really want to reiterate that these speaker series webinars are meant to be for general educational purposes only and should not be taken as medical advice. Always talk to your doctor about your treatment for GBS-CIDP, MMN, or related conditions. And especially today, Dr. Bluestein is going to be really focusing on pain and not so much the specifics of treatment for GBS or CIDP or MMN. In fact, we're not going to focus on, the specifics at all. We're really going to focus on the topic of pain today. So with that, I think we are good to get started. Dr. Bluestein, so great to have you. And why don't you start with a quick introduction of yourself, if you don't mind?
Of course. Of course. I kind of ended up doing pain management by accident. I am an anesthesiologist by training and worked over 20 years in the operating room. And although I've had medical problems going back to my childhood that were not always well defined or well cared for, I managed to function pretty well for quite a long time until I couldn't function very well anymore and could no longer work in the operating room after having a bunch of surgeries and other painful conditions, including a Tarlov cyst, which some people here may have heard of that or have had that happen to them. Anyway, so that's when I found out that I had a connective tissue disorder. And so basically started working on ways to help myself feel better. And in the process, realized that I could help other people feel better as well by taking what I had learned, helped me, and applying it to other people. So basically for the past, not quite 10 years, but getting there, seven to eight, I guess. I've really been focusing on integrative treatment for pain because there's a lot of people that are doing, like invasive integrated, the invasive, man, I'm having a loss of words already. What's the word I'm looking? Interventional procedures. There's a lot of pain doctors who do the interventional procedures, but there's not a lot of us that are looking at this from a holistic standpoint. So I started doing that, and then also, writing about it, and came up with an approach that I'm going to share with people today. And I have had some patients with CIDP, and it kind of regardless of the source of the pain, a lot of these principles can be very useful. So that's kind of how I ended up doing what I'm doing. And yeah, I'm excited to get to chat with everybody today.
Yeah, this is excellent. So I didn't get to read the bio I have on you, so I want to do that. But first, you mentioned, a holistic approach to pain. Can you define what that means a little more?
Sure. So I really like to get to know a person. I feel like it's really helpful to me to take a really detailed history. And so my initial appointments are anywhere between an hour and a half to 3.5 hours long, because I really want to do a deep dive into what's going on with the person and understand them as a person, as a whole person, what kind of things have transpired in their lives that could affect how they feel, how they function in their, family or their work situation. There's a lot of other clues that come out as I take this, much more detailed history and have them go through a timeline and things that really can help me help them feel better. And the whole goal is to have people improve their functional capacity and improve their quality of life. So I'm not big on focusing on what's the pain number. I remember at one point in time, I had a problem with my upper extremity, and the pain wasn't the problem, but I couldn't open a door. And so asking people their pain number to me is a lot less valuable than asking them, what can they do? What are the things that they want to be able to do that they can't do? How can we help them get to a place where they can do more of those things that will bring them, joy and, a better quality of life?
Yeah, so really looking at the whole person and their whole life. I really appreciate that. So I understand you have a presentation to kick this off with. And before we do that, I do want to read that Dr. Bluestein is an international speaker on the forefront of research on pain, hypermobility, and dance medicine. Your professional services include telemedicine visits, as well as workshops and lectures for groups. And some of that I think you mentioned already, but wanted to make sure I got your bio and gave you credit where credit is due. With that, let's take it away and get into it.
Okay, great. All right. Can you see my first slide okay?
Looks perfect.
Great. All right. Oops. Okay, so you already gave the disclaimer that this is information, not advice. So we can skip right past that. And I'm going to talk about the main approach that I use to treating people who have persistent pain. And I like to say persistent pain rather than chronic pain, because it feels to me less gloom and doom. Chronic pain sounds like it's never going to go away. And in some cases, it can either go away or at least get significantly improved. So I usually use persistent pain. So I'm going to be describing my approach, which the acronym that I use for that is MENS PMMS, and talk about some of the factors involved in pain processing, and talk about why chronic or persistent pain can be difficult to treat, but not impossible. So that's kind of a very, very rough outline. And first, let's talk about the definition of pain. So pain is always a subjective experience that's influenced by varying degrees by various different biological, psychological, and social factors. And I feel like people forget this a lot. So I feel like the biologic part gets forgotten by pain psychologists sometimes. They focus so much on the pain psychology, which is very, very important. And we can really use that to improve our quality of life and our ability to manage pain. But at the same time, we don't want to forget the biologic factors as well. And there's various different social factors, of course, that are important also. And pain and nociception are not the same thing. So we can't just be thinking about the activity and sensory pathways, which is the nociceptive part. Through our various different life experiences, we learn the concept of pain and its applications. I did a podcast interview the other day with someone, and we were talking about the differences as we learn through our childhood, how pain was perceived by our parents or injury or whatever. The difference if you were somebody who you fell and there was a lot of panic and oh my God, versus if you were like, brush it off, you're fine. I mean, in both extremes are probably bad. Probably somewhere in the middle is a lot healthier, if you will. And a person's report of a pain experience should always be respected and accepted as such. And I feel like something that I see a lot of people focusing on, which I would encourage people to try not to focus on, is validation from their physician. Your physician can't possibly know what it's like to live in your body. You want them, of course, to listen to you and treat your problem and take you seriously and all of that. But I don't think that they necessarily need to, understand the depths to which the pain, how severe it is, in other words. So I really do try to encourage people to focus on how the pain impacts their day-to-day activities, how their pain impacts what they want to do, more so than the numbers, because I feel like that can kind of start to get people down on a different path. Pain does serve an adaptive role. We actually know that there are people who have genetic defects where they don't feel pain. And you know what happens to those people? They die at an earlier age because they don't feel pain. So they get horrible infections that they can die from. They do all kinds of crazy things. They jump off roofs and they do all kinds of other things that those of us who feel pain, we're not going to do because we know it would be painful. So these people who don't feel pain have shorter lifespans. So pain is there to protect us. It is there to help, serve us in this way, but it can be problematic when it persists and doesn't necessarily maybe need to be there anymore. We know that even though, infants and other, animals that are not verbal, they might not be able to describe their pain, but we know now that they can still feel pain. I remember when I was in my anesthesiology training, they were telling us how it wasn't that long earlier where children having cardiac surgery were not given any opioids. So we're talking, these were infants with, cardiovascular, severe, like congenital malformations of the heart. They would have their sternum cut open and crack their chest to operate on their heart. And they were not given any opioids because they thought that infants did not experience pain. We've come a long way since that, thank God. But it's important to recognize that whether on either end of the spectrum, whether a person has some other thing going on or Alzheimer's disease or something like that, that people can still experience pain and we need to treat that. Okay, so what did this acronym stand for that I just mentioned earlier? Men's PMMS. And you can see here what the letters stand for. This is from, excuse me, a journal article that I wrote back in April of 2023 for a journal called Topics in Pain Management, where we talked about this treatment strategy in context of hypermobility, symptomatic joint hypermobility. But I've used this strategy for lots of other conditions as well, and it is often very, very effective. And we're going to go through each letter individually relatively quickly in the interest of time so we can get to questions and things like that at the end as well. So the first letter, M, stands for movement. It is very, very important to figure out what is the appropriate movement intervention that we can work on in order to get people moving better first and then moving more. Sometimes people think they need to just move more. We want to be using the correct neuromuscular movement patterns. So ideally, if you're having a lot of problems with persistent pain and you've not been moving very much, it's great if you can get to somebody who really does a very nice job of assessing movement, and they can really watch you move and figure out as best as possible what is the root cause or a couple of root causes of suboptimal movement and try to focus on that because that can really be very, very helpful. There's a lot of other factors that we need to consider, like the sensory, psychological, and motor processing factors that we need to consider when we're giving movement prescriptions. And we also know that there's a dynamic relationship within the nervous system and pain processing that is important to address. When we move, that can sometimes cause discomfort, and it's important to be able to distinguish between discomfort and actual harm. So sometimes something can hurt and it is causing harm, and other times something can hurt and it's not harmful. So it's important to make that distinction. And I often work with patients and I tell them, look at the green light, yellow light, red light type of principles. So for example, a green light activity is one that you can do and you can do it again the next day and you can do it the next day and you're not going to cause a flare-up. Red light activities are one that you do, and not only do you pay the next day, but you might pay for days afterwards. I remember I did a Zumba class and I kind of totally forgot about any of my medical problems a few years ago, and I was set back for months because I normally kind of really, kept my movements very conservative, and I was just having so much fun, and that was way, way into the red zone for me. The E stands for education. There's some studies that show that when we educate patients about pain neuroscience, that can really help them have, more realistic expectations for their treatment. And it can really help with working on their beliefs and their perceptions. I know when I first learned about pain catastrophization, and I know that there's been some discussion about should we get rid of the word catastrophization, but I first learned about that in any real sense. When I was working as an anesthesiologist, I was in a lot of pain on a daily basis. I had already had my Tarlov cyst surgery, but I was really, really struggling. I was back to work and I was in a call room and I was really, really miserable. And I stumbled across a YouTube video and they talked about pain catastrophization, but a light bulb went off because I thought, wow, so perhaps by changing my beliefs and changing what I think, maybe I can change how my body feels. And again, this is just one component of the whole picture, but by understanding how pain processing works and how the endocrine system and the immune system and the neuropsychological system, how these all interact within the central nervous system, that can help us modulate those pain signals more effectively. And we can get really clinical, meaningful improvements in what's called kinesiophobia and also the pain catastrophizing. And catastrophizing, by the way, is thinking that the worst is going to happen. Some of us are really good at this. I am really good at this. Some of us are kind of born more natural catastrophizers, and some of us are like my husband is on the exact opposite end of the spectrum. He always thinks everything is fine, and I always think the world's coming to an end. So between us, we probably balance out pretty well. So by working on that can be helpful. And kinesiophobia is the fear of movement. And when I first learned about this too, I was like, oh, that's what's happened to me. I am so afraid to move because it seems like I always get injured when I do move. So again, understanding the role of these, how these different concepts can play into our pain experience can be really, really helpful for our comprehensive treatment strategy. And there's been studies that have shown that in chronic low back pain, chronic neck pain, fibromyalgia, chronic fatigue syndrome, osteoarthritis, and post-surgical pain, that using pain neuroscience education has helped with positive changes in pain beliefs, improved pain coping strategies, and improved health status. I'm not going to go into a lot of detail about, pain, parts of the brain that are involved in pain processing and things, but needless to say, it is a very, very complex process. Pain processing is, we probably only really know actually the most basic, science when it comes to pain processing. There's so much more that we need to understand. But one really important thing is that emotional centers of the brain are involved in interpreting and contextualizing pain. So this really impacts how we think about pain. And these emotional centers of the brain, like the amygdala, are often areas that are more hyperactive in people that have hypermobility disorders. So we know that people have symptomatic joint hypermobility, like if they have a connective tissue disorder like Ehlers-Danlos syndrome, then there's actually been brain imaging studies that show that group of patients, at least in some studies, have a more hyperactive amygdala or fear center of the brain. And we know in lots and lots of studies that people who have joint hypermobility have higher rates of anxiety. So having more anxiety or being more prone to anxiety can definitely influence our pain experience. And another thing that influences our pain experience is mast cells. So mast cells are a part of the innate immune system that are part of the fast reacting immune system. And when they are activated, they can release, or they do release, a bunch of different mediators, including ones that sensitize both the periphery, meaning that the nerves out in our fingers and our arms and legs, and they also sensitize the central nervous system, meaning the spinal cord and the brain. So mast cells are supposed to react when we are exposed to, viruses, if we get food poisoning, chemicals in the environment and things like that. But some people have hyperactive mast cells, and this can definitely contribute to sensitization of the nervous system and higher levels of pain. Again, I'm not going to go into this in any tremendous detail at all. I just want to for you to see that pain involves both the inhibition. There are chemicals that are involved in inhibiting pain signals, and there's other things that are involved in facilitating pain signals. Okay, so and then we know that glia are, and I'm mentioning glia specifically because we're going to come back to glia. Glia are one of the cells that can be involved in this process. This is important because it is important to remember that a lot of these things that influence how much pain we feel, these are physiologic, not psychiatric processes, okay? So just because there are psychiatric things or mood challenges like anxiety, depression, et cetera, that can influence how much pain we feel, does not mean that, again, it's all in your head. Except I will say, if you think about it, everything that we feel in here. And I think that that's an important thing to remember, that we have the, I don't know how many people have seen that like map of the like what part of the brain, what part of the cerebral cortex is responsible for the foot, the hand, etc. There are parts of our brain that represent different parts of our body, but at the end of the day, we feel everything up in here. So all of these things that are shown on this graph are going to influence what happens up here. So that's the bottom line.
And Dr. Bluestein, we had a question come in, and I just want to clarify, all of this is applicable to neuropathic pain.
Absolutely, yes.
Yeah.
Yes, I
I have
treat
more
neuropathic pain a lot. Yeah.
I have more questions, but I'll save them. But I just wanted to point out the neuropathic pain part, and especially looking at where the brain is signaled. I'm assuming all of those signals still come up, even if it's neuropathic pain.
Yes. Yes, absolutely. I'm glad that you brought that up. I will. So I want you to know that I had to remove a bunch of slides because once I realized that you had some other like follow-up questions, and one of the slides at the beginning was, but I'll take just a minute now to explain. There are three main types of pain. There's nociceptive pain, which is related to direct or potential tissue damage. So that's like the classic, you get your hand too close to a fire kind of a thing. That's the more straightforward pain signaling that we often think of. And then there's neuropathic pain, which is related to a problem in the nervous system. So it could be in the peripheral nervous system, it could be in the central nervous system. And then there's nociplastic pain, which is related to the processing of pain signals. And it's a little bit confusing because there are places where people say, well, nociplastic pain should only be a consideration if you don't have any other explanation. But we really know that even when people have neuropathic pain, or if they have nociceptive pain, that puts them at higher risk of having nociplastic pain. Nociplastic pain being related to dysfunction of the software, basically. The pain processing software is contributing to the amount of pain that the person feels. So part of the challenge with neuropathic pain is that puts you at increased risk of having nociplastic pain. And oftentimes what I tell people is, I'm trying to get the pain brain calm down. I'm trying to calm down that fire, that like feeling like your whole body is on fire, and getting it so that you're still probably going to feel some pain, but I want to alleviate the suffering. That's really a much more realistic goal. And so, yes, this is definitely still applicable. The other thing that I didn't talk about at the very beginning of this is, of course, making sure that you have the correct diagnosis and that you're addressing the correct diagnosis with the most specific possible treatment. And then this is kind of to address the body as a whole. Excuse me, this approach is helpful for, in particular, that nociplastic pain. So I do appreciate that question. That is a very important question.
Yeah, very helpful. Thank you.
Sure. Okay, so the next letter, so we did M-E, and then now we're on N. So M-E-N, N stands for nutrition. And we know that foods that we eat influence our body chemistry. So they can increase inflammation or they can decrease inflammation. And there is a bidirectional relationship also between our central nervous system and our gut microbiota. So that's the bacteria in our gut. So that plays a very, very important role in how our body feels. Our gut microbiota make a huge amount of our neurotransmitters. So how our gut is functioning is hugely important. And sometimes we can really work on that gut microbiome and get people feeling a lot better that way. So the gut microbiome definitely influences the systemic inflammation and also inflammation within the central nervous system that can contribute to pain amplification and I'm not even going to try to pronounce this word, but basically pain going from acute to chronic, and then staying in that chronic phase. Whenever possible, it is really, really good to work with a dietitian or a nutritionist because yes, there's some general principles that are applicable to most people, but whenever possible, if we can get into the more nuanced recommendations and the more individualized recommendations, that is very, very helpful. So we like to look at the individual particular patient. How much inflammatory pain do they have? How much neuropathic pain? Do they have malabsorption? Do they have gastroparesis? So they have slow gastric emptying, et cetera. So the next letter, S, stands for sleep. And we know that chronic pain is associated with the desynchronization of circadian and biologic rhythms, and this can be very problematic. We know that melatonin also has analgesic effects and can act on beta endorphins, GABA receptors, actually opioid receptors, and the nitrous arginine pathway. And melatonin can also help improve migraines, fibromyalgia, irritable bowel, preoperative anxiety, and postoperative pain. The P stands for psychosocial. And we know that fear of movement is very, very common, and catastrophization is common. And we talked about that already a little bit. Prior injury also can increase anxiety and catastrophization about future injury. And unpredictable symptoms can lead to activity restrictions to avoid pain and other injury. Having somebody who is independent and an objective observer with the right skill set to talk to can be very, very beneficial, because I think one thing that a lot of people that do have persistent pain, that we often tend to forget is that the other people in our family or our partners, they have their own things that they're dealing with, and it's appropriate and important to be thinking about, well, what does each person need in the relationship, and how do we best get to a place where both people are able to support each other. If you are in a relationship, or if you're not, how do you get supportive people around you? I've had people say, I had to learn to love my family from afar because they were actually part of the problem, So having supportive relationships is often very, very challenging. So what I tell my patients and my clients, and by the way, the difference, in order to become a patient, I have to see a person one-on-one in my clinic setting first, which is either in Wisconsin or Colorado. But then clients, I have worldwide clients that I see, and I give them much more, general information and recommendations and things like I would write it in a book. I'll write it that way in their actual notes. And then a lot of the things, though, they can carry out themselves, or they can work with their local healthcare team. But what I tell people is, you deserve to have a counselor. It is not punishment. It is not, this is not something that means that you're weak. You deserve to have a counselor. I cannot tell you how many people I know who they are counselors or they're psychiatrists or whatever. They all have their own therapists. Because they know the value of having a therapist on their team and having someone that they can talk to and having someone that they can, bring things to. And I urge people, just like with physical therapy, when I urge people to not wait until you're in dire straits, I urge people to not wait until you're in dire straits to start working with a therapist or a psychologist. I think that's something that can be very, very beneficial, especially if it's the right person. I should also mention it's a little bit like dating. So sometimes you have to, try out a few people before you find the fit that works best for you. Okay, so M stands for modalities. So there's a lot of modalities that have some really, really good science behind them, including for neuropathic pain. So acupuncture actually has a lot of science behind it for relieving pain or improving pain levels. And oftentimes I feel like people may give up on this too soon, or it's kind of like physical therapy. I hear this a lot from my patients that perhaps they went to physical therapy and, maybe it caused a flare of their symptoms. And so they ended up not going back. And I urge people to, if they did have any kind of a problem, to go back to that clinician and say, this caused a flare of my symptoms. Is there something different that we can do, next time, or at least give them that feedback, because maybe that's a piece of information that's really helpful for them. Acupressure is where you actually press on various different points yourself. There's a lot of great science for that as well. And somebody might think TENS. Oh, I've heard of that. Transcutaneous electrical nerve stimulator. I've heard of that. I've tried that. I tried this many, many years ago myself. And I think that the important thing to know here is expectations. Back when I tried this, back when I was like at my worst, which was probably around 2010, is when I think I was probably at my all-time low from the standpoint of pain myself. I was in bad shape, spent a lot of time on the sofa. I literally would pace myself. I'd be like, okay, I can go up and down the stairs one time today. So when am I going to do that? I need to plan ahead. And now I go up and down the stairs as much as I need to. So it could, my point being that everyone's different, of course, but in some cases, at least, significant improvement is possible. Getting back to the TENS. Okay, so back when I was having a lot of pain, I tried acupuncture. I did not try acupressure, but I tried acupuncture. I also tried TENS. I didn't try either the Apollo Neuro or the Gamma Core or light therapy. But a lot of the things that I tried, I think I was doing what a lot of my patients and clients do, where I was expecting it to cure my problems. I was expecting to go from, like significant pain levels and significant impairment in what I could do on a day-to-day basis, and expecting it to give me this just like miraculous, like now my pain is gone and everything's fine. But I think that instead, if we try to think that if we can get 10% pain relief by using a TENS, or when we're in a really, really highly intense flared state, if we can use the TENS and that can bring us back down to the point where we can move a little bit more, that those are places where we can really maybe use some of these modalities in a way that is more appropriate and helps to keep our functional capacity at the best that it can be. There's some evidence for ozone being beneficial for injections, and it's one of those things where whether it's ozone, prolotherapy, PRP, we need more data for all of these things, but there is some data that can be helpful, especially here in Colorado, where we're at higher altitudes and, are not breathing in as much oxygen. I often will prescribe oxygen, even if people's blood levels or pulse oximeter levels of oxygen are within a normal or acceptable range. Sometimes using oxygen, getting a oxygen concentrator and using oxygen a few times a day for, like 20 to 30 minutes, 2 to 3 liters per nasal cannula. Sometimes that can be beneficial and can help, mitigate some of those flares. And the Apollo Neuro, excuse me, is a device that you wear on your wrist. It probably looks a lot like my watch, actually. This is not this isn't an Apple Watch or anything. I think it looks a lot like this one, though. It actually helps to modulate the nervous system. And I believe that last I looked on their website, I have no relationship with them, by the way. Last I looked on their website, they still had this like 30-day money back guarantee. So you could try it out and see if it helps. It can be very helpful for people who have dysautonomia or dysfunction of the autonomic nervous system. So they're kind of stuck in like fight, flight, or freeze. They get their heart races a lot. They feel like their digestion is kind of shut down. And that can contribute to pain, persistent pain. So sometimes, especially if people have like this combination of factors, I will recommend that they try this Apollo Neuro. The Gamma Core was developed more specifically for migraine headache, but can also be beneficial for other, painful conditions as well. Somebody that I interviewed for my podcast, Dr. Beth Darnell, who heads up the Pain Neuroscience Center at Stanford, and I apologize, I don't remember the episode number offhand, but she's done a lot of work looking at virtual reality, and they've found some really nice benefits from using those kinds of strategies. She also has a program called Empowered Relief. And she also trains people in these classes, and it's a 2-hour class. And they recently published a study showing that even 6 months later, after this 2-hour class, people's pain levels were overall, they were decreased. So again, I think education is huge. It's great that you're all here to learn more about pain and how pain processing works and how you can help yourself to feel better. Light therapy, this is something that I recommend a lot to my patients and clients. It's something I do a lot on myself. I do have an affiliate account actually with a company, the one that I use called DNA Vibe. And I use that a lot on, like, I'll use it on my shoulders, on my hips, various different parts of my body. And it has like a pad that has red light that is supposed to help improve blood flow and also improve collagen production. Oops. The next M stands for medication. So if you notice, out of the men's PMMS, there are 3 M's, and the last M is medication, because a lot of people have already tried a lot of different medications. So I don't usually lead with that. Although I usually do prescribe medications, I usually start with some of the other things first. In the first appointment, I often prescribe like something in every one of these categories. But it's very important to think of all the other things that can influence the pain experience besides medications, because I think sometimes we have unrealistic expectations about what kind of relief we are going to get from our medications. And that's why, we say the medication failed. It's also possible that the medication failed because of how it was tried. Either the dose wasn't correct, it wasn't titrated correctly. Maybe we had a reaction to the excipients, which are the inactive ingredients in medications. But if someone has a mast cell problem, where their mast cells, that part of the immune system, is hyperactive, they can be really, really sensitive to those inactive ingredients, the fillers and the capsules and those kinds of things. In pain medicine, a lot of the medications that we use are off-label, meaning that they're borrowed from other conditions. We actually have very few medications that are actually FDA approved for pain. I always encourage my patients to keep an open mind to new trials. So I do like to know, what all have they tried in the past? Why didn't it work as well as they had hoped that it would work? Because that's important. Obviously, if they had some severe allergic reaction, then that's going to affect, our decision-making process. But sometimes, it is important to try something again. Sometimes they were started at way too high of a dose, et cetera. And it's also important to be aware of both the placebo and the nocebo effect. So probably most people are aware of the placebo effect, and the nocebo effect is the opposite. So it means that if I give you a medication and I say, this is probably going to make you worse, which you would say, well, why would I take it then? Good question. Then it probably will make you worse. There's a really fascinating study that I used to share with a lot of my talks, that it's a pretty clean study from the standpoint, these are not people that are already in chronic pain. It's more of an acute pain type scenario. But what they would do is they in this study, they didn't just ask their pain ratings, but they also did functional MRI of their brain. And they would inject them with, I believe it was an analog of fentanyl. I don't think it was fentanyl. I think it was a fentanyl analog. Anyway, it was sufentanil maybe. So they injected them with fentanyl. They injected them with a placebo. Or did they, anyway, whatever it was that they did, the exact specifics, they would tell them, this is going to make your pain better, or this is going to make your pain worse, or they didn't say anything at all. And basically those expectations had a lot to do with their pain experience. So like when they said, this is going to make your pain worse, but they injected them actually with fentanyl, their pain didn't get worse because they didn't start out with pain, but they didn't get the big boost because then they were doing something to cause them pain, like they were doing like a pressure threshold test. So they found that the expectations made a big difference in not just like their reports, but also in the parts of the brain that were activated. We can also do pharmacogenomic testing, but it's also important to realize that that has limitations. So pharmacogenomics is where you look at the different parts, you look at single nucleotide polymorphisms or SNPs and see what areas where somebody might be like an outlier for how they process drugs. And so that can be helpful. These are some of the different medications that have been studied for persistent pain. And I share this list with you not to try to overwhelm you, but really more so to inspire hope that there are drugs in the pipeline and there are medications that are being repurposed for non-acute pain. And I really believe that in the future, we will have more and more options. Well, why don't we just prescribe opioids? So although opioids can be very helpful with short-term intermittent use, we just need to be very, very careful about more long-term use. They can overactivate glial cells. And remember, we talked about glial cells a long time ago and how glial cells can be involved in sensitization of the nervous system. So we want to be mindful of that for sure. They can also activate mast cells, and mast cells, when they release their mediators, they do a number of things. One, they can degrade connective tissue, so they can make any kind of connective tissue weakness worse. Two, they cause inflammation, and they also cause allergic type phenomena and abnormal tissue growth, things that we don't want, basically. So we do believe that the dysregulation of glial cells and mast cells contribute to the pathogenesis of chronic pain. Long-term, it's also problematic due to tolerance. You have to keep escalating the dose often in order to get the same effect. They disrupt the endocrine system. We also can get physical dependence. So then, now we have to always have that drug in our system or else we feel terrible. And they also disrupt the endogenous opioid system. So we have this delicate endogenous opioid system in our bodies. And if we take exogenous or external opioids, that can, really, cause some problems with our own endogenous opioid system. It's not to say that opioids aren't sometimes indicated. Definitely, sometimes they are. And sometimes long-term opioids are appropriate and necessary. We just want to be very selective in who we prescribe these to and make sure that we are always choosing the right drug for the right patient at the right dose for the right period of time, et cetera. Okay, so low-dose naltrexone. This is something that I have found very, very beneficial on my patients. I take this myself. It is actually an opioid antagonist. So it blocks the opioid receptor. But at very, very low doses, it has less affinity for the mu opioid receptor and instead binds to something called the toll-like receptor 4. And it can actually help break that glial cell activation cycle and reduce cytokine release. And cytokines are what contribute to inflammation. There was this recent scoping review that I have listed at the bottom that demonstrated improved pain severity, hyperalgesia, and hyperalgesia is when something that's normally only slightly painful is very painful. Improved physical functioning, improved quality of life, improved sleep in centralized pain conditions. There was a variable time to benefits, but overall, benefits tended to accrue over time. Side effects are very rare, and when they do occur, they usually dissipate over time. Sometimes we need to change up the formulation, change up the excipients in order to get rid of those side effects. Rarely do we have to discontinue the dose. Sometimes we have to just back way off and go more slowly on our titration. But we also want to keep in mind if we are having side effects, could it be related to the excipients? Again, in some of these studies, they found an increase in efficacy over time with eventually a large subset of patients seeing some benefit. You do always want to discontinue prior to scheduled surgery where you might have opioids. When I had to have surgery not long ago, went off my naltrexone for the surgery like a week beforehand, and I had a headache every single day. And prior to that, my headaches, I've had migraines and other types of headaches, had been very well controlled. And as soon as I went back on my naltrexone, my headaches went away again. Obviously not automatically cause and effect, but it was pretty good evidence to me. Cannabinoids can also be very helpful. Our bodies actually produce endocannabinoids, which act on CB1 receptors, which are in the brain, and CB2 receptors, which are in the peripheral tissues and immune tissues. We know that CB2 is also expressed on microglia, which is a type of glial cell, and regulates proliferation and migration of immune cells. So these are also very important for the immune system. And by the way, both LDN and cannabinoids can be very, very helpful for neuropathic pain. Exogenous cannabinoids can reduce pain signaling and allodynia. And allodynia is where something that's normally not painful at all is painful. So an example of that I often give is like the sheets, when the sheets are touching your feet, that can cause pain. And also can help, these medications also can help with anxiety. Some of you have probably heard of CGRP antagonists. These are medications that are often prescribed for migraine, but because CGRP is also involved in hyperalgesia and central sensitization, these medications may benefit other types of pain as well. Ketamine is something that probably a lot of people have heard of, especially now that Matthew Perry died in a hot tub with ketamine as one of the things in his bloodstream. In the appropriate dosing, this can be very, very helpful for reversing that central sensitization. Ketamine is a dissociative anesthetic agent, and it's a very, very powerful anesthetic agent. It's used often in veterinary medicine because it's very, very cheap. And, we tend to not really worry too much if our animals hallucinate as much as if people hallucinate. I prescribe ketamine as a very low dose sublingual tablet with the goal being not to hallucinate, the goal being, to take the edge off of pain. I do know some of my psychiatry colleagues who prescribe a much higher dose, and I've had patients and clients tell me this, that they say, you're going to take this medication and then you're just going to stay home and do nothing for 6 hours. And to me, that's a little scary. That's a little like, I'd rather prescribe very low dose, take the edge off, rather than having someone have this horrific experience at home. There are some people working on prolonged release ketamine tablets, which will hopefully be a safer and more efficient option in the future. There are some very important relative contraindications, which include pregnancy, active psychosis, cirrhosis of the liver, severe cardiovascular disease, and increased intracranial pressure. Supplements can have very, very powerful biologic effects. This is the last letter of the acronym, by the way, the last S. And we need to be very careful, though, because they're regulated by the FDA as food, not as drugs. And they can interact with other supplements or other medications. And we already talked about the 10% rule. Whenever possible, you want to use food before nutraceuticals. I'm going to just, in the interest of time, just mention a couple of supplements really quickly that I think are the most important. Magnesium is one of them. Magnesium is involved in many, many different functions in the body, including protein synthesis, signaling, and neurotransmission. This is very important for inhibiting central sensitization and helping to improve pain hypersensitivity. So magnesium is one of the first supplements that I often consider, but it's also important to consider what type of magnesium salt are we going to think about. There's a lot of different magnesium salts. There's magnesium sulfate, magnesium citrate, magnesium threonate, magnesium glycinate, malate, et cetera, and they have slightly different effects. So what the exact type that we use depends on what's going on with that particular patient. Omega-3 polyunsaturated fatty acids can also be very helpful. They can improve inflammation, and they also have anti-nociceptive or anti-pain or pain-relieving properties that are independent of the inflammatory pathways. I believe this is the last supplement that I'm going to talk about, vitamin D. Vitamin D is very, very important. We know that the deficiency of vitamin D is very, very common in people with fibromyalgia and chronic musculoskeletal pain. This is extremely common in the patients that I treat, extremely, extremely common. Sometimes I get back, vitamin D levels in a single digits. Oh, I should mention, there is no reliable blood test for detecting magnesium deficiency, but the blood tests for vitamin D deficiency are very reliable. So that's an important point to note. So hypovitaminosis D actually activates inflammatory cytokines, which can cause more central and peripheral pain. And that can also contribute to poor muscle mass and impaired muscle strength, things that we definitely don't want if we already have a pain problem. We also want to make sure that we have good vitamin D levels in order to have the appropriate amount of immune response. And in this study, they looked at vitamin D supplementation, and they found that that helped activate immune cells. And actually, this line here, wherever you see this like red line with the little perpendicular part at the bottom, that's where something is actually being blocked. So it actually blocked pro-inflammatory cytokines, helped activate fibroblasts, but then blocked prostaglandins, which are related to having more pain, helped activate other cells and decrease pain, decrease inflammation, decrease chronic pain, and also decrease oxidative stress. So in summary, this is one type of approach that I use for treating people with persistent pain, and it's an iterative approach. So when someone comes back and they give me feedback that, this is doing better, but maybe something else isn't as good, or, we kind of, or maybe like, it doesn't happen that often, but I've had people come back for the first follow-up visit and I'm 90% better. It's like, that's amazing. Doesn't happen all the time by any stretch. I wish it happened all the time. Usually this is a slow approach. This is like a be patient. We're going to hang out together. We're going to have a few visits over the first year kind of a thing. But I keep revisiting what parts of this can we work on in order to improve your quality of life. The goal, as I mentioned earlier, is to improve quality of life and physical functioning. And this is not by any means an exhaustive list. This is just a sampling of the things supported by the literature and/or that I have found helpful in my clinical practice. The biggest thing I want people to have is hope. I remember when I was at my worst, I felt completely hopeless. And that was an awful feeling. And I remember going to an anesthesia conference because I was still like thinking, oh, maybe someday I'll be able to get back to work. And I still wanted to learn. And I remember sitting in one of the lectures and hearing these, scientists, pain doctors talking about their research. And I sat there and I thought, wow, as a patient, like I had no idea that all of this was going on. So I want people to know that not only are there things that we can do now, but there are some very, very smart people working on getting a better understanding of, persistent pain, neuropathic pain, what types of therapies, might be successful, trying to get more data. And so I think there's a lot of reason to be hopeful. And last but not least, I wanted to say thank you so very much to the GBS-CIDP Foundation for having me today. You can visit my website for more information, hypermobilitymd.com. I do have a podcast called Bendy Bodies with the Hypermobility MD. It's on YouTube as well now, and you can visit that at bendybodiespodcast.com. You are welcome to email me or connect with me on social media. And I hope you found this helpful.
Oh my gosh, thank you so much. That was so informative and educational. I could praise it forever, but in the interest of time, we do have a bunch of questions. So if it's okay with you, we're going to dive right into them. And are you okay if we take a couple extra minutes, or do you have a hard 2:00 stop?
No, I'm okay.
Okay, well, thank you very much for the extra time. So let me try to get through some of these questions. The one that really jumped out to me first was about insurance. So specifically, this was about insurance, if their oxygen saturation levels are within the normal limits and getting that oxygen therapy approved. But then it also got me thinking of insurance coverage for kind of the broader group of these recommendations. Do you have anything to add there?
Yeah, that is a big problem. Our insurance system is terrible and is so incredibly frustrating. It just is. It is really, really problematic. Our insurance companies are much happier to pay for expensive surgeries and procedures than to pay for things like this that, and I understand they want data and everything to support what it is that we're doing, but it's the insurance piece is really, really frustrating. A lot of us who are doing this kind of work, don't take insurance because I'm seeing patients tomorrow, for example. I am seeing 2 people. If you think about it, if things, oh, sorry. Zoom, thank you so much. So, I have colleagues that'll see, 40 or 60 patients in a day, and I usually see 2, 3, 4 patients in a day if they're new patients. You know, so it's insurance, just they don't value the time that we spend with patients. And that is correct, that if your oxygen levels are okay, insurance is probably not going to pay for oxygen. So if you happen to live in a place where you can access, you know, like getting like an oxygen canister, and you can try that first, because those are relatively cheap, and you can just see, like, you know, wait until you're in pain. Although probably a lot of people are going to say I'm always in pain, but, you know, try it at a time where you think that you would actually be able to tell if it makes a difference or not, before actually having the investment of purchasing, you know, on your own, an oxygen concentrator, because yes, they are fairly expensive. I know at one point I had a link for one that was in the like $200 something range. And then you have to, of course, buy like the nasal cannula, but you can use the same nasal cannula for quite a while. But then when I looked more recently, it seemed like they were more expensive than that. So that is insurance is definitely a problem.
Yeah, well, and then I want to thank you then for putting out some of these resources for free, such as the podcast and doing these webinars, because we want to try to get this information out there to people who can access it and actually use it. But some of those barriers to access can be so strong. So thank you for making some of these resources available for free. And hopefully, you know, that can help start somebody's journey in whatever way is accessible to them, which we know can be so difficult.
And that is exactly why I do the podcast for free, because I know that, you know, not everyone can come see me one-on-one. And I do want to, I just haven't, I need a little more help getting this set up. But another thing that would be very helpful, and if anyone has access to this, like in their hometown, which they might, group medical appointments. Something that a lot of clinics will do. And that's something that I would really like to start doing. So that way, you know, it's less costly for each person, but it's not as impersonal as just listening to a podcast.
Yeah, absolutely. All right. So first of all, I want to thank everyone for their patience with all of these questions that have come in. You know, we're not going to get to all of them, which we did anticipate. So please forgive us as we just try to sort through them. There's another one that stood out to me here about somebody in very sudden, acute, extreme pain. So kind of, especially thinking, I think with GBS, CIDP, and MMN, some of that pain can happen kind of very sharply and very quickly. Do you have any techniques, you know, quick if we can be, techniques to try to help and manage and calm that pain in the moment? So some of that like acute pain management versus, like you were saying, the persistent pain management.
So first of all, if you go to my website and if you sign up for the email list, literally the current opt-in is a flare handout. So it's like a 3-page flare document. Now, that being said, I know this is really challenging, but trying to distinguish between, is this truly a flare of my previous problem, or do I have a new acute problem? It is very important. So, and I know it's hard to do that, but it's, you know, trying to assess, okay, does this fit with what I normally have, but it's just worse, or does this feel different? And if you do end up going to the doctor or to urgent care or something like that, make sure that you really, really stress how this is different from your normal, because it is sad, but a lot of times they look and they see, oh, you're someone who has chronic pain, and they tend to, unfortunately, it's very problematic that they don't pay more attention.
Yeah, absolutely. Similarly, a question came in about, you know, having no pain maybe throughout the months of the diagnosis journey, and then all of a sudden having nerve pain. Any thoughts on why that might happen?
You know, it's not that I don't necessarily have any thoughts as to why that might happen, but man, if you were my patient, or, you know, if I would certainly hope that somebody would look into why that was the case. Because anytime there's a change, we should be trying to understand why there's a change.
Well, that kind of goes back to one of the first things you said in the discussions with your doctor about the pain, focusing on what you can't do all of a sudden because of pain. And that actually felt, when you first said it, felt a little bit radical to me, because the first thing I want, right, is for someone to validate and say, yes, you're in pain, and that is, you know, valid and legitimate, but that might not always happen. So I can totally see where you're coming from and how that might be difficult. But at the same time, I'm like, I just acknowledge that I'm in pain, right?
Right, right. It is. It's really, really hard. And I encourage people to think of when they're going to the doctor, it's kind of like making a tweet, or I guess now you call it an X. I don't know. But you have a certain number of words that you're going to be able to get in. So you want to use them very, very thoughtfully. And I think if when I have people tell me I used to be able to do all of these things, and now I can barely get off the sofa, and I really want to be able to do XYZ. For me anyway, I mean, I can't speak for everyone in my profession, of course, but to me, that is very, very helpful information.
Yeah. And we have a couple other webinars about communicating for success at doctor's appointments.
That's
And
great.
yeah, and we focused those discussions on especially kind of as CIDP progresses, people lose, the function and things like that, and focusing on that. So it's very interesting to think about applying those same principles to pain. Again, to me, it feels a little radical because just validate my pain. Just tell me, yes, you're in pain and you need to do something about it. But sometimes that's hard. So shifting my own thinking is very interesting. One last topic. I wrote this down and then we did get a couple of questions about it. Is the mast cells, because there is an autoimmune component to the conditions within the GBS-CIDP MMN community. There's an autoimmune component, and I noticed the theme of the immune system popping up. So maybe this is less of a question and more of a statement, but I'm very interested, I think, to your point, as a holistic approach, really looking at the immune system and things like that. So maybe the question is do you see any relationship between autoimmune conditions and pain?
Oh, definitely. And in the population that I see, which, symptomatic joint hypermobility, yes, there's a much higher prevalence of autoimmune problems, and the mast cell it definitely plays a significant role with a lot of that sometimes. And, it's funny because in the beginning, when I first started, working on myself and then eventually other patients, I didn't necessarily take that as seriously, the mast cell component, but I noticed, a number of years later, I was preparing a presentation at a mast cell conference on pain. And I learned a lot through working on that presentation. I was like, wow, the mast cells really are super important. So I started actually shifting more of my approach to that. And I noticed my outcomes, my patient outcomes definitely seem to get better. Mast cells, they cause inflammation. They cause a lot. We need them. They're absolutely essential for life. You cannot be alive without mast cells. But we also want them to stand down when we don't want them to be reacting.
Yeah. That kind of, to me, ends a little bit hopeful because there's a lot of work, it sounds like, being done and better understanding pain and better understanding the relationship of pain and these other conditions going on. So I hope that that gives the audience some hope for their persistent pain, even though it might be really, really hard right now, that there are people really thinking about this, people like you thinking about this and working through it. And hopefully in the future, we'll have better tools and strategies. With that, we are a couple of minutes over, and I just really want to thank you for being so generous with your time, with your knowledge and your expertise. I want to thank our audience for joining us today, and for all of the questions. I'm sorry that we couldn't get to all of them. We did have a lot in there, so please forgive us. If you do have something pressing that you want to follow up on, you can email us at advocacy@gbs-cidp.org, and we'll try to get you an answer. With that, I just want to wish everyone a wonderful weekend. Thank you, Dr. Bluestein, for your time. And please join us next month for our next speaker series, and keep an eye on your email for a survey about this event. All right. Thank you, everybody. Have a great weekend.
Thank you for having me.